دم كان شغال ما بقاش شغال. المايكس هنا. لما نخلص ده شغلنا المايك تاني. ما هو لازم يكتب، مش ضروري تعملي انترودكشن خالص تدخل اعتذار.
يعني ايه الاثنين مع بعض؟
طب ممكن تقف معانا بس نشغل ده الاول عشان نفتح، اصل هو مش هو بتاع الصوت. ممكن حد ينادي لنا حد مسؤول عن الصوت؟ ممكن يا دكتوره تشوف لنا حد مسؤول عن الصوت لان كده مش عارفه. حضرتك المسؤول عن الصوت مش كده؟ لا واللي هناك شغال هيجرب كده يا دكتور.
كده اشتغل. في حاجة
بسم الله الرحمن الرحيم. Good morning, my colleagues. It's my pleasure to start the morning session on female pelvic malignancy. What do gynecologists expect from radiologists? It's my pleasure to share this session with Professor Osama Hatta, Professor Hani Hafiz, and Professor Salok. Also, this session we have distinguished speakers and sincere colleagues and friends. There is minor change in the schedule. We will start with Professor Rasha Kamal. Then after Dr. Rasha, Professor Mamdouh Mahmoud. Dr. Rasha will speak on endometrial versus cervical carcinoma. Please, Dr. Rasha.
Bismillahirrahmanirrahim. The title of my lecture is The Role of Imaging in the Staging of Endometrial and Cervical Carcinoma. I'll start my lecture with two cases. The first case is a 45-year-old female complaining of menorrhagia. This is the T1 sagittal images, the T2 weighted images, and the contrast images. Sorry. As you see, there's a large mass extending to involve the body, the cervix, and involving the upper two-thirds of the vagina. The mass appears dark on the T1, bright on the T2, and it shows contrast uptake on the contrast images. The second case is a 55-year-old female complaining of menorrhagia. There's also a big mass involving the endometrial cavity, the cervical canal, and may extend to involve the upper part of the vagina. These are the contrast images, and as we see, the mass lesion did not show contrast uptake on the contrast images. I think both cases are evident that they are carcinomas, but the question is it an endometrial carcinoma invading the cervix and vagina, or is it a cervical carcinoma invading the uterine body and the vagina? And is it actually important to make the differentiation between both tumors? And if we say that it is a carcinoma, can we stage this carcinoma or not? And the aim of this lecture today is to identify what the radiologist is expected to do whenever he encounters a case of an endometrial or a cervical carcinoma. There's a common saying which says that دكتورة سلوى احنا غيرنا الترتيب مخصوص عشان حضرتك. A common saying which says that an ounce of prevention is worth a pound of cure. But actually this statement becomes questionable when we are dealing with cancer. because could we really prevent cancer or no? And according to the WHO, 40% of cancers are preventable, and one of these cancers is the cancer cervix that we're going to discuss today. Then the answer should be yes. And what's more than that is that it's not just prevention of cancer development, but actually prevention includes advances in diagnosis and treatment that reduce suffering and mortality from the disease. We as radiologists play a fundamental role in the management of cancer patients. And a good radiology report should fulfill the expectations of both surgeons and oncologists. And whenever we encounter a case of cancer, we are asked first to look for this cancer or detect and diagnose cancer. And when cancer is diagnosed, we have to move another step and try to stage this cancer or know how far the cancer has spread. And lastly, we have to determine if treatment works, or in other words, follow up this cancer. And we'll start by stage 1, which is looking for cancer or detection and diagnosis. And of course, to know what is abnormal, we should first know what is normal. On an ultrasound examination, we can identify changes in thickness of the endometrium together with cyclic changes. In the early proliferative phase, the endometrium appears as a thin white line, about 4 to 6 millimeter in thickness. In the mid-cycle, it becomes thicker and it attains the famous triple line appearance, while in the late secretory phase, it is thicker and becomes around 18 millimeter, and it appears as a white stripe. The postmenopausal endometrium looks exactly like the early proliferative endometrium. And one measurement that we should know is that the postmenopausal endometrium should not exceed 4 to 6 millimeter. So my first SMS for you is that the premenopausal endometrium should undergo cyclic changes, while a postmenopausal endometrium should not exceed 5 millimeters. And because measurement of the endometrium is very important, then we have to know how to measure the endometrium exactly. And looking at the picture here, we should not include the junctional zone within our measurement to the endometrium, because the junctional zone, which is this dark line, belongs to the myometrium and it does not belong to the endometrium. And so my next SMS is, do not include the junctional zone in your measurement, because this will add around 4 to 6 millimeter from each side to the measurement of the endometrium. On an MRI examination, we can identify changes in thickness and we can see excellent zonal anatomy, especially in the sagittal T2 weighted images, where the endometrium appears white in color, the myometrium of intermediate signal, and what separates both is this dark line, which is the junctional zone. Another phenomenon that we should know is that when we inject contrast and then we take early images, we have what is known as the differential enhancement. Because the cervix contains a large amount of fibrous tissue, when we inject contrast in the early images, we will find that the uterine body uptakes the contrast while the cervix takes delayed contrast uptake. Unfortunately, on a CT examination of the pelvis, we do no measurement of the endometrium, we do not see cyclic changes, and we have no zonal anatomy identified. And therefore, my next SMS for you, please do not recommend CT examination to investigate suspected endometrial or cervical carcinoma. It's only indicated if we have a diagnosed case and we want to do extra pelvic staging. Then when should we suspect the presence of endometrial and cervical carcinomas? Although both cervical and endometrial carcinomas arise in the uterus, the tumors have quite different etiologies, clinical and imaging features. And we'll make a simple differentiation between both types. Looking at the endometrial carcinoma, it usually presents in the 6th and the 7th decades, and only very few women are diagnosed under the age of 35. The precursor of the endometrial carcinoma is the presence of unopposed estrogen, which causes proliferation of the endometrium, and actually endometrial hyperplasia is the first step for the development of an endometrial carcinoma. If we look on the cervical carcinoma, on the other hand, it usually presents in the 4th and the 5th decade, and it is commonly diagnosed under the age of 35. The cause is completely different. It is due to squamocolumnar metaplasia, and to understand this, we should have a close look on the cervical canal. The cervical canal consists of two parts, an endocervix, which is delineated by columnar epithelium, and an ectocervix, which is delineated by squamous epithelium. And it is the junction between both where most carcinomas start. During the childbearing period and due to repeated pregnancies and delivery, this squamocolumnar junction travels to become outside the cervical canal. And this explains why most cervical carcinomas are endophytic in nature in old individuals and exophytic in nature in young individuals. On an ultrasound examination, endometrial carcinoma appears as a thickened endometrium. It's not as wide as we are used to see the endometrium. It appears heterogeneous. It's an endometrium which is thicker than 5 millimeter in postmenopausal, and an endometrium which does not show cyclic changes in a premenopausal female. And one important feature that we should know about endometrial carcinoma is that it causes very late stromal invasion. And when we apply the Doppler to this endometrium, we might see increased vascularity. On the other hand, on an ultrasound examination, the cervical carcinoma appears as a bulky cervix, and both the exophytic and the endophytic show early stromal invasion. And this is how it appears on the sagittal and on the axial images. And when we apply the Doppler, one of the earliest signs of a cervical carcinoma is to see cervical increased vascularity before even you can see a mass. And so my next SMS is for you. Please always start with an ultrasound examination and do not forget to apply the Doppler, because we can see signs that we cannot see with other imaging modalities. And second, from their names, an endometrial carcinoma starts within the endometrial cavity, while the cervical carcinoma starts within the cervical stroma. On an MRI examination, the endometrial carcinoma again appears as a thickened endometrium, which appears darker than the normal bright endometrium that we are used to see. And when we inject contrast uptake, in contradiction to the myometrium, which takes early contrast uptake, an endometrial carcinoma takes delayed contrast uptake. Cervical carcinoma, on the other hand, appears brighter than the cervical stroma. And when we inject contrast, it takes early contrast uptake in comparison to the delayed contrast uptake of the cervix. So, some more SMSs. The uterine body enhances early while the cervix enhances late. The cervical carcinoma, on the other hand, enhances very early, and the endometrial carcinomas enhances late. And now we've diagnosed the presence of a carcinoma, we have to move another step and try to stage this carcinoma. And before we stage, we have to know our landmarks. We have to know 3 junctions to delineate the extension within the uterus, and 3 interfaces which delineate the extension outside the uterus. And we'll start by the 3 junctions. Of course, the most famous of these junctions is the junctional zone. It is a regular and continuous dark line on the T2 weighted images, and it shows early contrast uptake in correlation with the adjacent myometrium. The second junction is the cervicocorporeal junction, and it is marked by the site of the internal os. It is the site where anteflexion occurs. It is the site where the angle of the bladder points, and what's more important, it is the site where the wide endometrial cavity changes into a narrow cervical canal. The third junction is the cervicovaginal junction, and it is the site of the external os, or easier than that, it is the site where the myometrium ends. The 3 interfaces, the first of which is the parametrium, which is usually assessed in the axial images. It is this dark line which delineates the parametrial extension. The second interface is the interface between the bladder and the uterus. And the third interface is the interface between the rectum and the uterus, and they are both delineated by a very thin white fat plane. We have also to remember that we should do an axial T2 weighted images to see, for example, liver metastasis. Sometimes we can identify implants, and sometimes we can see back pressure changes which might delineate the presence of extracervical or parametrial extension with cancer cervix. So some more SMSs, we have to look carefully on the sagittal view because it is essential to detect upward, downward, anterior and posterior extension. We have to look on the axial view, which is essential to detect lateral or parametrial extension, and do not forget to look at the T2 weighted images of the abdomen to see extra pelvic spread. If we look at the different stages of an endometrial carcinoma, stage 1 is a tumor confined to the uterus. A stage 2 is a tumor that invades the cervical stroma but does not extend beyond the uterus. A stage 3 is a tumor which extends beyond the uterus but not outside the true pelvis. And the stage 4 is a tumor which extends outside the true pelvis. And when we look at the management lines of each stage, we will find that it is completely different from one stage to the other. And therefore, the next SMS is that the preoperative staging of endometrial carcinoma is one very important job that a radiologist must do. Our first case is a post-menopausal female patient who complained of vaginal bleeding. This is her sagittal T2 weighted images. As we see, the endometrium is thickened. It should not exceed 5 millimeters, and it appears heterogeneous and less bright than the normal endometrium. And this is how it looked on the contrast. It showed delayed contrast uptake, and in this stage, this is an endometrial carcinoma stage 1. I'll have to pass some cases to save time. This is another case. She's a 60-year-old female with history of breast cancer under tamoxifen therapy, and this is an appearance which we can see due to endometrial hyperplasia in patients which take tamoxifen. The endometrium is thickened with cystic changes and minimal increased vascularity. If we look at the sagittal T2 weighted images and the sagittal contrast images and have a closer look at this part, we will see that the junctional zone here is abraded. And once the junctional zone is abraded, then it's no more a hyperplasia, and this is an endometrial carcinoma stage 1B. This is the case that we showed at the beginning. The endometrium is thickened, it's darker than usual, and it showed delayed contrast uptake. And actually this was an endometrial carcinoma stage 2. But we have to take a look on the axial T2 weighted images of the abdomen, and if we see this metastatic lesion in the liver, then it's no more a stage 2 and it jumps to a stage 4 carcinoma. And when we look at the cervical carcinoma, we find that the stage 1 is a tumor that is strictly confined to the cervix. Stage 2 is a tumor extending beyond the cervix but not to the pelvic side walls. And stage 3 is a tumor extending to the pelvic wall, and the stage 4 is a tumor extending beyond the true pelvis. And again, if we look at the corresponding management lines, and there's a tendency now to preserve the cervix and do irradiation for the cervix, and we find that we have different lines of management for each stage. Then again, my next SMS is that the preoperative staging of cervical carcinoma is another very important job that a radiologist must do. This is the first case. As we see here, we have a bulky cervix. The cervix should be the narrowest part of the uterus. And when we applied the Doppler, the cervix showed increased vascularity. The sagittal T2 weighted images shows a lesion which is bright in color, and it showed contrast uptake. And we have to look on the axial images to see if there is parametrial extension, and in this case there was no parametrial extension. And this is the case that we showed at the beginning. It's bright in the T2 weighted images. It showed early contrast uptake with preserved, all junctions, all interfaces are preserved, and actually this was a case of a cervical carcinoma stage 3A. Sorry, but واحد يبقى مستعجل اتعطلت بزيادة. أنا عشان الصلاة بس يا دكتورة سهلة. And now we move to the third step, and that is to determine if treatment works. And to know there is recurrence, we have to know where recurrence occurs. Recurrent endometrial and cervical carcinoma usually occur at the site of the vaginal wall. The remaining patients develop pelvic or parabortic lymph node involvement and may show signs of systemic spread manifesting as hepatic, pulmonary, or osseous metastasis. And to assess the presence of the response of therapy, especially in cases of cervical carcinoma, we can use either the conventional MRI by measuring the size of the tumor before and after therapy. Like, for example, in this case, we have a large cervical carcinoma here, and this is how it appeared after irradiation. We can also use the dynamic contrast MRI images, and by plotting the time signal intensity curve, exactly like we do in the breast, the character of the curve will change by the response to treatment. And lastly, we can also use the diffusion weighted images by measuring the ADC value, and we will find that before the irradiation, the value is low, and it increases to reach, for example, here it was 0.6 and 0.6, and it reached 0.9 by the end of irradiation. This is a case showing how the cervix looks after completion of the irradiation. It appears attenuated. This is another case showing vaginal vault metastasis. And to end my lecture, we should always remember that cancer is a word and not a sentence. And to the world, a cancer patient may be counted as one person, but to that person himself, he counts to be the whole world. And actually, a cancer patient might believe the world has stopped following cancer diagnosis. And we should always remember that it is our role as radiologists, surgeons, and oncologists to change this. So doing a good job simply means making it a new start for these patients. And thank you all. And at the end of my lecture, I want to thank Professor Soha Talat and Dr. Sahar Mansour and Shaykhane Fakhri, because they have supplied me with most of the material introduced in this lecture. Thank you.
Thank you very much, Professor Rasha. We have time for short question or comment.
ما نخليها في الاخر في طارق عشان في الاخر احسن.
طبعا الدكتور ممدوح يغير. ممكن very short question regarding endometrial versus cervical carcinoma. What's the role of elastography?
But I know that nowadays there are trend to try to differentiate both, because the cervical carcinoma is more tough than the endometrial carcinoma. But actually, I haven't done any work in this field.
Yeah. Thank you.
So, Rasha, I have one question. You touched the role of duplex in cervical and endometrial carcinoma. Do you think is it sensitive and you can rely on it?
But the presence of vascularity, we had cases, we didn't see anything in the cervix except increased vascularity. And when we performed the MRI, we found small cervical carcinomas within the cervix, and they weren't apparent on the ultrasound examination. So the presence of vascularity sometimes indicates the presence of the cervical carcinoma. Of course, not always, because we have a lot of cases with cervicitis, but at least if she has...
It's a bit subjective to the operator, the doctor. It is subjective.
Yeah, at least I mean that if you have increased vascularity, just to advise the patient to do a pap smear. If she has any metaplastic cells, then she should proceed to an MRI.
اوكي. الحقيقه انا النهارده صباح الخير جميعا الاول. بيسعدني ويشرفني النهارده ان انا اقدم زملائي الجمال، والسيشن ده الحقيقه فيه كوكبه من الاساتذه والدكاتره وزملاء القصر العيني اللي هم كلهم الحقيقه يعني الواحد مش قادر يقول مين احسن من مين. طبعا لازم نشكر الدكتوره رشا كمال على المجهود والعطاء المميز في إعداد والتحضير للمؤتمر ده، وهي ده دايما يعني ظننا بيها. في الحقيقة طبعا الدكتور ممدوح محفوظ بحب أقدمه لأن هو أخويا الصغير والكبير في نفس الوقت. ممدوح محفوظ غني عن التعريف، والحقيقة هو كل واحد في حياته عنده اختيارات كتيرة بيختارها تساعده، لكن ممدوح محفوظ بالذات اختار ان هو دايما يعني حياته كلها وعمره كله يخليه يقدم العطاء المتميز بتاعه من المحاضرات عشان تبقى دي صدقة جارية بالعلم اللي بينتفع بيه. والحقيقة أنا مسافر معاه في كل مكان في العالم، منين ما بننزل من المطار كده معرفش ايه اللي بيحصل، يلاقي ناس ده ممدوح محفوظ يشاوروا عليه. فالحقيقة يا ممدوح ده في ميزان حسناتك إن شاء الله، وأنت أخ وزميل عزيز عليا، وإن شاء الله ربنا يوفقك دايما. اتفضل. بالنسبة لمحاضرة النهاردة هيتكلم على الأوفيريان ماس ليجن a diagnostic challenge.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. في الأول بشكر طبعا أساتذتي كلهم وعلى رأسهم الأستاذ الدكتور سلوى فتحي for this introduction. وأنا this is my first time to participate in this particular meeting. I have the pleasure to do so. وهي ما كنتش متخيل إن هو بهذا الحجم من التنظيم والحضور، وأتمنى إن أنا أكون يعني عند حسن ظنكم، واللي كان يعني حاسس إن هو هيستفيد من المحاضرة يستفيد. معظم الحاضرين عارفين إن المحاضرات كلها بتتسجل عن طريق السوفت وير موجود على اللابتوب، وبعد كده أنا بدي نسخة للدكتورة رشا أو اللجنة المنظمة، وهي يا إما تبيعها لحضراتكم بالسعر اللي هي شايفاه، يا إما مش مشكلة على الدكتورة رشا، التجارة مشروع، أو إنها تحطها على الويب سايت، وهي إن شاء الله في خلال 10 أيام هتكون موجودة على الويب سايت بتاعي اللي هو موجود على اليوتيوب إن شاء الله. My talk is about how to diagnose the ovarian masses, and you know that we have many imaging modalities to assess the pelvis, especially the ultrasound, the CT and MRI, and we may have the role of the plain X-ray to have some idea about what's going on in the pelvis, as I will show you. The CT scan of the pelvis is usually performed in the female cases after oral administration of contrast material to delineate the bowel loops, and also intravenous contrast material to enhance the vessels and to discriminate between masses. And this just two images showing how good the preparation of the patient by the orally administered contrast material. MRI, you know that we have 4 machines: the closed magnet, the open MRI, the extremity MRI, and the dynamic MRI, where you can examine the patient in the weight-bearing situation while she is standing. Then we use an MRI superficial or surface coils, and this is one of the coils that we use for imaging of the female pelvis. Then we have to state some of the facts before going into the lesion, how the signal appearance of the different structures in the pelvis. Actually, you know that we have the T1 and T2 weighted images.